Okay, let me see if I can clarify a couple things. I thought Zyprexa was associated with the possibility of causing or at least exacerbating seizures. All antipsychotics have that risk. Clozaril is the worst of all of them. What is the drug that they prescribe right after a head injury, like a concussion? And do psychologists prescribe such a medicine? Wouldn't be prescribed by a prescribing psychologist. No, because that's a medical issue. See if there are other questions I can try to figure out. Who makes up these questions? Everybody does. There's no right or wrong question on these things. It's just the idea of beginning to think about how you go about trying to tease out an answer to the question. You're going to walk away the same way. When you take the PEP, you're going to feel the same way. You'll be wondering, what are these questions all about? Somebody has an echo. Yeah, the definition of the dodo bird effect is essentially this. The fact that most psychotherapies are of equal efficacy when compared in meta-analysis, that's called the dodo bird effect. And there's been some research moving towards trying to understand that mechanism. And in the book, on page 19, there's that chapter that I mentioned, the integrating clinical psychopharmacology with practice, that second chapter. In this book, let me get this. This is the book we're talking about. Okay, let's see. I got to do everything backwards here. When it's down, okay, we'll go up, and I'll try to get this in. It's the 19th. It's the second chapter in it, and it's on page 19. If you get anybody to copy that for you, you could probably ask somebody who has a copy of the book to get it for you. Okay, there's it. Okay, somebody still has an echo, or have we solved that problem? Martha, I understand you're bilingual. I don't know what I can tell you other than the fact that the basic strategy is what you want to do is you read every question and try to figure out how to rule out things that you know are not to be true. And it is a bit confusing, I know that. So it's hard to get used to the way the questions are being asked, and the content is sometimes vague and not specific. So the more you read these questions, the more likely you'll be able to respond in a proper way. I'm not going to spend too much more time on this. These are just examples of what they might ask in this area. They're not intended to be real-life examples. They're just kind of getting you to think about how questions would be phrased. And I just want you to make sure you know the content areas. This is an okay, here we're part of 4, which is physiology and pathophysiology. So you're going to see the content is indications of referral to other healthcare providers. If you read that question, that would make sense. Cardiovascular system physiology and pathophysiology across the lifespan. So that would be rhythm and rate disorders such as prolonged QT intervals, and then there are relationships to psychopharmacology and psychopathology, blood pressure changes secondary to psychotropic medications, mitral valve prolapse related to panic disorder. Okay. That's what they're saying on page 19. Oh, yeah, you remembered. Thanks. That's good, 2 lungs. Okay. This is another question about cardiovascular physiology. Resistance equals viscosity of blood times length of the vessel divided by the power of the lumen's radius. This is a ridiculous question. That'll never happen. A. No, the answer is C, but that's a ridiculous question. You're not going to get that. Okay, which of the following? This is related to system physiology and pathophysiology, rhythm and rate disorders such as prolonged QT, and their relationships to psychopharmacological. Prolonged QT is an issue, and it is always asked. QT, so which of the following statements is not true? The QT interval is dependent on heart rate. Prolonged QT interval is benign. I mean, you can go right there. Prolonged QT interval. That's not good. What drugs do that harm our heart are they prolong that QT interval, and that's where the risk is, where the heart will go into sudden stop, sudden heart death. Same sort of question, which of the following is not true of cholinergic innervation of the heart? And the answer is all of the above. So it's not true. It is effected via the vagus nerve. It shortens the QTR interval. It is parasympathetic autonomic function. It relies mostly on the muscarinic 2 receptors located in the sinal node, atrial node, and the AB, atrioventricular nodes. All of the above are true is the answer. Tricyclic antidepressants can affect EKG, increasing heart rate, prolonged PR, QT, and QRS intervals, producing arrhythmias, B and C, and all of them are correct. So all of those things can happen with our drugs, okay? And which is not true. I read that wrong, so I corrected it. It's the correct answer. Yeah. Pancreatitis is associated with which drug? It's valproic acid. Depakote. No, they shouldn't be doing that. They should not be asking that much. They were told not to do that. But I can't guarantee that anymore. In the beginning, we wouldn't do that. You would have to ask in an affirmative way, not which is not, that kind of question. We wouldn't do that. They do that. Apparently they do. Since PEP3 was the person who most recently took it, I guess, he could probably remember that. Did they ask in the negative? Yes, they did. So tricyclics, we know, all have anticholinergic effects, and that's how it affects the heart. That's pretty clear. Which of the following are most likely to prolong the QT interval? It's D, A, and B. Ziprasidone, thiaridazine. So these questions go on and on at length with this. You guys are free to read this. There are a couple other things I want to do. I want to move through this section a little bit more quickly. Okay. Same cardiovascular type questions. Just go through those. Here's some pulmonary. Metabolic acidose is not associated with Cheyne-Stokes respirations. I don't think you will get that. That's another question that's probably too specific. Pulmonary system physiology and pathophysiology across lifespan. So the beta blockers are generally contraindicated for asthma for their effect on the beta-2 receptors in the bronchioles. Which of the following is not true? Hypoxia can result in dementia. Is a lack of oxygen to the brain. Well, that's true. And sure, if you were hypoxic long enough, you could develop dementia. So can resemble Alzheimer's disease, but does not have a gradual progressive nature. That's true as well. So it's got to be D. This is the renin-angiotensin system sequence. I don't think they're going to ask you that, but it's there for you to look at. So it's which electrolyte is wrong? Sodium is a cation that helps to balance fluid levels in the body and facilitates neuromuscular functioning. Potassium is a cation that helps to regulate neuromuscular function and osmotic pressure. Calcium is a cation that affects neuromuscular performance and contributes to skeletal growth and blood coagulation. Magnesium is an anion that influences muscle contractions and intracellular activity, and chloride is an anion that regulates blood pressure. So magnesium is not an anion. Right. Okay. So metabolic alkalosis is associated with hypochloremia, resulting in mental confusion, lower breathing, paralysis, and muscle tension and spasms and triggers. Which electrolyte imbalance is associated with disorientation and seizure and coma? Hyponatremia. Low sodium. The neurotransmitter most associated with sexual functions dysfunction is serotonin. Those are the ones we get the biggest complaints with. Two big complaints with serotonin drugs are lack of sexual drive, performance, and weight gain. First pass metabolism, basic hepatic pathophysiology and physiology. Okay, the answer is B. You're beating me to it, so we'll just go ahead. I want to get through these quickly. So we're part of the hepatic system now. After first pass metabolism, the drug is usually what? More water soluble, right? Not lipid soluble. Okay, medications that do not rely. Remember that lot business before? So this is confusing, right? You get this? So this is a foil here to make you get off task. So gabapentin, lithium, and lorazepam, none of they do not pass through the CYP450. Lorazepam is up here as well. Lorazepam is here as well, right? You see that? Temazepam, that's that lot, L-O-T, but the alprazolam is what spoils that answer. Symptoms of metabolic encephalopathy, all of the above. Irritability, lethargy, depression, disorientation, coma, delirium, and confusion. Carcinoid tumors, I'll play another row, all of the above, so I'm not going to, just want to skip through this. Just again, we're talking now about endocrine functioning, like Cushing's disease, what's it associated with, adrenal medulla involvement. It's not, actually, not, excuse me. I read that wrong. Going too fast. Addison's disease is almost always asked. What's it associated with? Adrenal insufficiency, hypocortisolism, aldosterone, hence hyponatremia, asthenia, but not anxiety. Oops. Here's your Cushing's, and then there's a pseudo-Cushing's. It says, which of the following conditions can cause mild clinical and laboratory findings similar to those in Cushing's disease, termed pseudo-Cushing's disease, and it's D, all of the above, alcoholism, depression, and eating disorders. Okay. more endocrine. This is let me just, that's too long to read. You guys can look at that. Okay, which is not true association between lithium and resulting disorders. Lithium equals hypocalcemia, lithium diabetes insipidus, lithium equals hyperparathyroidism, lithium is associated with hypothyroidism. So it's hypocalcemia. Which protein is most abundant in the blood plasma? I think we mentioned this already, was the albumins. I'm going to get through these. Serotonin is stored outside of the brain, mostly what? Where? Platelets, blood platelets. So it's also heavily in the gut, but that's not being asked here. It's not showing you that as an option. Which is not correct regarding anemia. It is a deficiency of platelets in blood plasma. It's not. It's erythrocytes and hemoglobin, leads to hypoxia and jaundice. Hematocrit is percentage of plasma in blood, percent of free protein in plasma, percent of red blood cells in the blood. None of the above. It's C, percent of red blood cells in the blood. Okay, let's see what we got right. Yes. SSRI, are you asking me if SSRIs have equal side effects, sexual side effects? Anthony? I can't read that first word. Or are you asking me about the mixed ones like duloxetine? Or you have norepinephrine and serotonin. I can't quite read that word, that first one. Are they still there, Anthony? Yeah. Okay. Yes. You think it might not be because of the norepinephrine, but the serotonin can be significant. But these SNRIs they change a little bit depending on your doses. So if you're giving 30 milligrams of Cymbalta, you're really going to see that drug as more a serotonergic drug. If you give them 120 milligrams of Cymbalta, it's going to act more like a norepinergic drug. So in that sense, it might be a little bit better for the sexual functioning at the higher dose, but I haven't seen any studies to prove that. Let's see. Bupropion ideal for avoiding sexual dysfunction if a patient can tolerate it. Frequently, yeah. If I have somebody on an SSRI and they're doing real well, and yet they're complaining about that, that's one of the things I try. Bupropion. I usually start out with. Some people I know just give like a 75 SR, but I typically give a 150 with it in the XL version. It seems to work fairly well for some patients, but not always. And then you can switch to the new drugs, or you could go straight to Wellbutrin if you wanted to, if it was just simple depression that you were treating. But if you have a significant anxiety, you don't want to do that. We talked about that before already. Remeron has few sexual side effects, but it makes you eat like no tomorrow. And that can have a secondary effect on your sexual appetite. Do you go straight to bupropion or try something else first if they are on SSRIs when they complain of the sexual dysfunction? I try to augment it usually with the Wellbutrin first to see if that works. If it doesn't, then I'm going to have to rethink it through and may have to get them off of it and place them on something else. It just depends. Okay, so Wendy, depends on the individual. Rule out the anxiety, the anorexia, and bulimia. Yeah, of course. Plus getting dates. Yeah. Yes, Remeron. Okay. So I think we got all those questions. Okay, percent. Oh, we did that already. All right, now let's see. These things are long. There's agranulocytosis. I'm going to kind of jump through this for you because I really want to get to some other things. You can look at the content here and see this is complete. Pretty much every physiological kind of function that they're thinking is important are in this list, okay? So you have this musculoskeletal, dermatological functioning, and here we go with a question with alopecia, okay? So obviously mood stabilizers do it, antidepressants, fluoxetine, TCAs do it, antibiotics, antipsychotics, excuse me, anxiolytics can do it. So you'll see that problem. And it's equal in men and women. This is systemic lupus. Nice question there. We won't bother with that. You can see it. Just go through these and just try to kind of imagine what the answers are. You can peek and look if you want, but it'd be better if you just try to think through it and see what your response is, and then try to understand why it was correct or why it wasn't. Let's see. I want to get out of this section 4 real quick, so that you get a chance to look at all the different sections. Here's one that's associated with complex behaviors involving multiple body systems. Okay, sleep disruption, secondary to antidepressant medication, psychopathology, and sexual dysfunction. Serotonin is a neurotransmitter with a major implication in which of the following conditions? Excuse me. There we go. Make your best guess. Most people are going to say B, and I think that's correct. Okay, this is the 5th area. So it's knowledge of the psychological assessment and history-taking procedures. Let me go back. Content is a biopsychosocial pharmacological assessment, and it's monitoring 10% of the test items. You can read through here, and you'll see that there's things: knowledge of the psychological assessment and history-taking procedures, comprehensive individual and family medical history, etc. This is a mini mental status report, kind of a question. I mentioned that already. These are the cranial nerves, which cranial nerves control hearing. These are simple little factoids, which cranial nerves control shrugging of the shoulders and turning of the head. You obviously know that is. But what turning of the head and shrugging of the shoulders is number what? Right. Number 11. And which cranial nerves control the movement of the tongue? Number 12, right? Everybody knew that, right? Okay. And which nerves do swallowing and gag reflex? Okay. So we have the vagus and the glossopharyngeal nerve that's involved in that. Okay, the answer to this one would be, which one? A. Swallowing and gag. Well, these are more questions. All right. Wait. I don't know what that is. This is wrong. This shouldn't be here. There's a chunk of this missing.
You hit the wrong button, Doctor, and fast-forwarded to the end of the presentation.
I did? Yeah, I figured. It was my fault. Let me go.
That's okay. Hold on a second. I'll fast-forward you.
Okay, great.